The common phrases or responses a woman should watch out for that might signal that they are being dismissed or just actually heard is kind of what there's one thing you said was, I'm not interested in whatever it is that you're trying to show me. What else should a woman look out for?
I think I know that our listeners here on the show are primarily perimenopausal and menopause. I would say if you've never had anxiety in your life, if somebody has anxiety all their lives and this is just your MO, it's different. But if you've never had anxiety in life and suddenly you're really anxious or depressed or fatigued, before you go on medication, because and you are suddenly being told, oh, that sounds like depression, that sounds like anxiety, I would say you're being gaslit, but not in a malicious way, but they've reached a conclusion based on all that they know. So how do we know who is anxious or depressed? Just to be really clear, it's not magic. There's a questionnaire. Your primary care has a questionnaire, and if you answer X amount of points, you'll be depressed. If you answer X amount of points, you're anxious. And the next thing that we know how to do is to give you medication. That is the art of diagnosing depression and anxiety. It's a protocol, it's a list, there's a score. This score gets therapy, this score gets medication. So you might say to yourself, wow, look, this is what I scored. I scored a 9 on the PHQ-9. I definitely need some medication. But you've never been depressed before. I would caution you to say that this is gaslighting in the sense that you're just being driven into a protocol. So question that. If it doesn't make sense, like, wow, I've had patients who are savvy enough to say, but I don't feel depressed. Even though my score is really high, I don't feel depressed. Same thing with anxiety. A quick diagnosis of some sort of mental illness instead of dealing with a physical part of it would be a red flag for me. Because at this point, if anyone or your listeners have been listening to podcasts enough to know that even mental illness is secondary to physical illness. So if something's happening physically, that would be a red flag for me.
Yeah, to me, it would make sense if you're just a primary doctor and you see a woman of a certain age, around the perimenopause age, who's having these. You could always prescribe her medication, but it's, to me, the low hanging fruit is, okay, you're in menopause. Let's check your hormones, or let's try hormones, and if it doesn't work, fine. Like, then we can move on to more advanced protocols. But it seems like the least invasive would be looking at the hormones and topping them up, if that would help. And if talking about somebody who's in the early perimenopause stage, she's probably just a little low in progesterone. Like, you don't need to give her the whole gamut, but just a little progesterone cream may help. Like, it's such a simple, easy, safe, and cheap solution rather than going down the whole rabbit hole of antidepressants and titrating up and titrating down and weaning off. Like, it seems such more complicated.
They're not going to change. And I want you to know that for the average clinician, what you describe is quite the opposite. It's much easier to prescribe antidepressants than to give someone progesterone, because you think it's easy because you've been educated in it. And you think it's a rabbit hole of depression medicine because you've not been educated in depression medication. So the average clinician would much rather give Prozac than to start messing with hormones. They've not been schooled on hormones. And so I'm glad
I don't know how to prescribe an antidepressant.
Exactly.
I'm more comfortable with hormones.
Exactly.
So I haven't been trained in that. So.
Exactly. So you think it's simple, but I'm glad again that you said, I wish doctors would, because if I really want your listeners to stop wishing that doctors would anything. I want your listeners to start accepting doctors for the skills that they have in the areas that they have and not expect a single thing more. And get the beautiful thing, unlike partners where for monogamous, we're not going to have multiple partners for multiple things. The beautiful thing about here is that you can have multiple doctors for multiple things. And find the strength. Again, if they're jerks, don't stay there. But if someone's great and they just are not great in menopause, then still stay with that person who's great and go somewhere else for menopause. It's the wishing that creates that emotional distress for our patients.
I felt it right there.
Right there.
You're right. I want to throw out some phrases that may make doctors take your menopause questions seriously, because I created a reel. I actually did very well, this one, on Instagram and Facebook as well. And I thought, I guess it was pretty useful for some women, but I'd love to hear your thoughts as a clinician. Are these too aggressive? Is it acceptable? Or maybe you could tweak it into a better question. Are you ready?
Ready.
Okay. This is disrupting my daily life. I need more than this is your new normal or it'll pass eventually.
Are we talking to a primary care person?
Yeah. Then a woman coming in needs help with menopause. These are menopause questions.
Great. Expect a referral to GYN.
And the doctor says, yeah, it'll pass. And I just heard this yesterday. I hear this over and over again.
Oh yeah, I hear it all the time. It'll pass.
It'll pass when 10 years.
And then what happens once it passes? Oh, yeah, that's fine. Just expect a referral to someone who knows. Don't expect your PCP to suddenly be comfortable talking about hormones.
Okay. I've tracked my symptoms consistently. There's a clear pattern I want to review with you.
Okay. Again, Your PCP might review it with you,
Hmm.
and then we'll order the labs and imaging appropriate depending on what symptom we're dealing with. If you say like your heart is fluttering, they will check for make sure your thyroid is not overactive. If they
Hmm.
say you're very tired, they'll give you a continuous glucose monitor if you feel energy crashes. Once they're done with their tracking, they're going to shrug their shoulders. So again, say thank you so much for exploring that with me, because you might need them in the future. And then take your tracker to someone who's more nuanced. In the truth is, I used to practice functional medicine one-on-one. I would never take on a patient that didn't first go to their PCP. So a good functional medicine or integrative practitioner is going, and you're going to come in and say, I have all these symptoms. The first thing a good one should say is, did you go to your PCP first? Did they tell you nothing's wrong? And if you say yes, like, great, you're in the right place. Mm-hmm. So the last thing you want to do is to go to a functional medicine person for the first time with your symptoms, because you really want all that done. So the point here is, even if your PCP does that stuff and they find nothing, that was still a really important step. It was not a waste of your time, because their job is to make sure you don't have cancer or something crazy that's going on that, or God, right, that you have to go and be in the system for. When they find nothing, you didn't waste your time. You crossed something off a list. You crossed off that, great, I am not dying. But then you're like, but my symptoms are still like this. I'm no longer in the right room. And then you go to that provider, and that next functional provider, the first thing that they should say is, did you see your PCP yet? And you're like, yeah, of course, here's all my tests. Great, now I'll do my tests. So keep going with that tracker.
Oh, I'm glad you said that. That's interesting, because I have these reels that I put out interviewing women all over the world, 5 questions about menopause, literally just stopping them on the street. And then after the reel, I have a call to action. If you need support, just comment the word support and I'll get to you. And you, of course, you get all these messages and I have to figure out a way to answer them all. But the first question I ask is, did you see your doctor yet about menopause? And you just saying this is like, oh, good. Actually, I was doing the right thing, because I do this. It's for the same reason. I don't know if she's in her age. I don't know if this is cancer. I don't know if this is totally different. So if she's it's kind of for the same reason. So I'm glad you mentioned that. And I hopefully, yeah.
And every time you go, people say, I went to the ER, they didn't do anything. I'm like, no. You went to the ER and they didn't find an emergency, so they dismissed you. That's great news. I went to my PCP, they couldn't find anything. That's great news. Like, I want us to start understanding, when the people in the ER and the cardiologist, they don't find anything, you did not waste your time. This is excellent news. Keep going.
Okay, these next questions, I'm like, I know what you're going to say. Now I think,
okay, let's do them anyway.
This reel was like, okay, not as practical as this whole podcast interview. Because here I am trying to get a woman, have a doctor who's not educated in menopause, to take her symptoms seriously. But yet what you're saying is the best that they can do is give you a referral.
Let me ask you a question. In your regular life, if you meet someone, let's just say who has a different political view than you, are you going to get them to take your view seriously?
Yeah, no.
You can't make another person do anything.
Yeah.
All you can do is navigate the obstacles.
Exactly.
Yeah, and that's the challenge. That's the thing I hear all the time on social media, is a various spectrum of complaints against the system. God bless, ain't nobody changing. So what are we going to do right now? Are we going to get angry? That's not going to help. So how are you taking back ownership of the exam room? And that's not by challenging them or forcing them to change. It's really just like, okay, those are your views. Amazing.
Yeah, it's crazy. Yeah, you're so right. I'm so glad we had this talk, because you're putting things into perspective. Because I think we all don't know that there's medical gaslighting, but we've maybe felt of it. There's 80 to 90% of the women feeling it. Okay, it's clear. We know what it is. We know how to identify it. But now we're not trying to change somebody who cannot change. We're just going to put them to the side for whatever they're good at, and then go seek out the professional in that space.
Right.
So thank you for clearing all that for me.
And added to that, before we sign off, is like, really start thinking, because we have this, like, we hold doctors at such high regard, and we should hold all humans at high regard. But I really want you to know, like, your electrician could be a great electrician, even though you don't agree with any of his political views. And I think that we could see that happening all the time. I am sure if I talked to my electrician, he would probably not be pro the things I'm pro, or it doesn't matter. He's a great electrician. So if your PCP is against supplements and against hormone replacement, or I can't talk about hormone replacement, it doesn't matter. Like, just use them. They are electricians. I bring them not down, because I think electricians are amazing. I can't live without them. We're plumbers.
They may be the highest paid people in this AI generation. So.
Exactly. Bring them on the same level. Just start treating them as just levers on the team. Use each one to their skill, and just lower your expectations because it's the only way to survive.